I think beyond all the research on sexual dysfunctions, I guess the best expertise that I can put forward is that being in a field that comparatively has lesser men, I guess, when you are in your training phase, especially considering the situation of sexual dysfunctions in India, uh, most number of people who actually seek help for sexual dysfunctions turn out to be men because of the taboo associated with it and things like that. Relatively, men seek more of sexual dysfunctions, and when you are a trainee in during your training period, obviously most of them would be comfortable talking to the male. So you can probably say that the interest in sexual dysfunction was not there at the beginning, but as and how I started seeing more cases of individuals with sexual dysfunction, it's probably very eye-opening also for me at that point of time to realize how misinformed and um, how talking about something like sexual dysfunction itself is a big deal. And it's to an extent that's how we society also make it. But nevertheless, I would like to probably take all your verbal consent, or I'll give you guys like a moment of thought because of the nature of the topic, right? Maybe it's important for us to remember that this workshop of this particular presentation is going to have discussions. It's also going to push you to kind of probably talk a little bit about sexuality and sexual intercourse, about anatomy of male and female physiology, and some erotic aspects also. We may speak about all of this, which maybe in some families, some societies, some groups may consider this as sensitive in nature. Some of you may have religious reasons why it is not okay to talk about this, may have some slight uneasiness related to this also. It could vary to severe distresses also for some of you. So if you guys want to take a moment to consider not attending the session because of this, because of the discomfort that you may feel, please feel free to do so. But I would like to have all of your consent. Maybe you can just type it out in the chat box. You can probably put yes, um, or no. You can put it up in the chat box to just so that I can move ahead. If you have any doubts related to what you are in for, whether there would be some other information, I would be happy to kind of answer those questions also before we proceed. Okay, all right. So many of you are marking yes. I'm not seeing any no's. Okay, I guess all of you have given yes, I think. All right, fine. Let's say if any of you feel if any of you want to stop me in between, please feel free to do so. Mics, please switch it on when, if and when you have questions or you have contributions. Video, I always would prefer it on, depending on your internet facilities and things like that. All right. So moving ahead, sexuality, right? Now, you hear about sexuality, and usually this comprises of four things. And uh, can people come up and probably tell about what is your understanding about these four various components of sexuality? What is the difference between sexual identity, gender identity, sexual behavior, and sexual orientation? Um any contributions from you guys? What is sexual identity, and what's the difference between sexual identity and gender identity?
So can I?
Yeah, yeah, please go ahead. Go ahead.
So, sexual identity is something that we are born with, like our biological, whatever the reproductive system that we have.
Hmm.
And gender identity is what we relate to more. You can be a male, but you are more on the feminine side. You
Hmm.
can be a female, and you're more on the masculine side. I think
Right.
that is the two difference between the two.
Huh. You're right. Sexual identity is usually related to the reproductive organ of the child. So usually people try to call it as sex assigned at birth, right? Because small babies don't anyway choose their sex, right? I mean, it is assigned at birth, and as the child grows up, more gender-related constructs come in. So gender, as you all know, is more of a socially constructed norm about what constitutes a man or a woman. Now, your gender identity can vary from identifying within that binary or even outside that binary also. It is possible that one could identify outside a conventional male, masculine, feminine binary. You can identify yourself with a lot of other uh, identities also, non-binaries. There were recent news reports of eminent personality naming his child with a non-binary name, right? And we also probably need to differentiate between the three and four, that is sexual behavior and sexual orientation. Can someone differentiate both of that? What is sexual behavior and what is sexual orientation? Anyone? Are they the same, sexual behavior and sexual orientation?
Okay, I'll
Yeah,
respond.
yeah.
Sexual behavior is probably the way you express your sexual desires
Mm.
through different sexual acts, while sexual orientation is uh, who you are attracted to, which could be again male, female, or across all of that, or not any of that and all.
Not any of that also. Correct, correct. Sexual behavior would include certain, your desires. There may be sexual fantasies. There are probably behaviors that are self-stimulating, or in scientific terms, you call it autoeroticism. Auto means by self, eroticizing yourself. Certain behaviors, masturbatory activities, all of them will come under sexual behavior. Your pursuits, onto how you pursue sex in terms of your romantic relationships, your sexual partner relationship behaviors to attain sex, all of them will fall into sexual behaviors. Sexual orientation, on the other hand, is the nature of the object, that is your sexual impulses, which are very innate, to what object here is does not mean physical object or materialistic object. It could mean that it could be about human figures, and very Freudian object also this could be, right? To what uh, nature of individuals or objects is my sexuality directed towards, that will determine my sexual orientation. It could be homosexual, it could be heterosexual, it could be bisexual, it could be pansexual. There are multiple orientations also, right? So these are all interrelated, however they are not the same, and it's very important for you to differentiate between. And let's start a little bit of an ice breaking on a discussion topic. I want some people to tell me, why do people engage in sex? Simple question, open topic. Why
So,
do
to
people?
satisfy their sexual urges or impulses.
Okay. If you're talking about sex as an impulse, if sexual need as an evolutionary need of some sort, what is the impulse about? Is it you're talking about some sort of a satisfaction, or are you talking about any other?
Yes, sir, the pleasure and the satisfaction that they might gain from it.
Yeah, yeah. So impulse may include the satisfaction or the sexual pleasure that individuals gain from it. That is definitely one reason why individuals tend to have sex. Any other reasons?
There is an innate need to procreate.
Definitely, there is a evolutionary need to procreate. That could also be an impulse, right? I want my genes to survive. I'm so great, so I want a kid also as great as me, right? So your selfish gene theory, as you talk about in evolutionary psychology, it is a need for individuals to make sure that their gene is is existing and surviving. Procreation is definitely a reason why individuals tend to have sex. Then, what are the reasons?
It may be one of the physical needs of the body, just like hunger, thirst. So,
It is true. It is a need of the body, as in some vegetative functions are definitely involved. Like, your body responds to sexual cues. That is true. However, it is definitely, it's not uh, fatal to not engage in sex, right? It is definitely not life-threatening. If it is probably definitely life-threatening to not have your food on time, or you know drink on time, your water on time, but people don't usually. It's life-threatening usually to kind of not engage in sex, right? So need here being, what is the need? Physical need, as in.
more for a mental well-being.
Yeah,
There may
mental well-being. Huh. So what contributes? What part of sex contributes to the mental well-being? Why do people feel good about the fact that they can have sex?
There's a release of endorphins while having
There
sex.
endorphins, oxytocins, there are multiple hormones that are releasing. More than that, there is a lot of self-related components also. You know, when you are able to have sex, there is a certain sense of competency that comes in. You feel competent as an individual. You feel comfortable. You feel disinhibited. A little relaxation that comes along with it. You also, there's a slight ego satisfaction also about yourself when you are successfully able to have a healthy sex life, right? So a lot of self-related needs also comes in. Any other reasons that uh, people have to engage in sex?
They want to feel that sense of intimacy with their partner.
Definitely. Yeah, good point. Sometimes it's very important for individuals to have a sexual relationship within marriage and within relationships, so that the intimacy between two individuals also kind of come along, right? So for the relationship needs, more than physical needs, individuals try to engage in sex. So these are all the four reasons. One is procreation, pleasure, intimacy, and self. These are the four reasons why individuals tend to engage in sexual activity. It is important to procreate and let your or the gene to survive. From an evolutionary perspective, you do it as a recreational, enjoyable activity. You do it as a part of a intimate activity between two people, and you also may engage in sex for some personal um egoistic needs of yours also. Egoistic, not again from a layman point of view, from a psychological point of view, ego from Freudian language, right? So some gratification also happens with.
Sir, is this
Yeah, tell me.
um, with regard to associating with the Freudian theory? Would it be only the sense of gratification, or could it be the act of domination?
Depends. It wouldn't be that all individuals who engage in sex may not be always domination exactly. But however, I think what you're trying to also probably bring in here is the Freudian um, conceptualization about aggression that is also there, right? Considering that it is a quite a primitive need of yours, Freud also conceptualized aggression as something that is a need to distract that is there in all the individuals. So, to an extent, the primitive nature of sex does involve some amount of aggression also. That is probably one of the reasons why dominance submission kind of a scenario very often gets conditioned to the idea of sex also. But there are problems with that also, actually, which I will discuss about as we go ahead. But yes, it is sometimes considered to be some sort of there are power plays that you see within sexual encounters. That is definitely there. We will definitely come into that as we discuss about the interventions also. Right. So let's talk about sex therapy.
Yes, so was
Oh,
that about sexual deviance? I'm so sorry to intervene.
sexual deviance.
Yes, sir, because submissive or dominating or any of those practices which are beyond the general set of boundaries of performing a sexual act. Was that it? Will you be covering up sexual deviance as well?
Deviance is definitely not something that I have planned for this presentation, but uh, we are not necessarily talking about deviant sexual behaviors when we are discussing about, say, dominance or submission. It need not necessarily mean that uh, these behaviors are not necessarily considered to be sexually deviant, actually. Sexually deviant behaviors could be something like, say, um, fetishes that individuals may have. You may know that sometimes kids actually start forming their sexual preferences very early. There may be classifications of disorders where individuals tend to get attracted to inanimate objects, may find pleasure of sex through acts that are considered outside social norms, such as voyeurism, peeping, and non-consented touching, and all these behaviors. They are usually considered to be sexually deviant. But uh, dominant submission, to an extent, is actually quite common in most sexual encounters. It can be deviant if the behaviors may cross the normal conventions about pain and pleasure. For example, there are disorders of um, asphyxiating behaviors for dominance and for submission. Such autoerotic asphyxiation is a way in which you try to strangulate yourself to kind of, some lack of oxygen that you feel actually leads to some sexual arousal. An interesting story behind that is actually during the time of public hangings, individuals used to find that after the hanging is conducted, some of the individuals used to get an erection after death, or during the time of death. So, noticing this genital difference, that is when individuals started identifying a lack of oxygen to the brain sometimes leads to a arousal, actually. So, this is the reason why individuals started trying suffocation and choking and acts like, suffocating themselves, and all these are considered to be deviant. But to some extent, some amount of power play, turn taking of dominant submission within the sexual intercourse is actually quite normal. So within sex therapy, something that you advise to individuals also to do is do turn taking, right? If for one moment, if say someone is being in the dominant role, uh, take turns, and probably after 2 minutes the other person can be in the dominant role. In that case, it's a mutually consented method, and does not usually need to be called deviant, actually. Did I answer your question? Hello, did I answer your question?
Noted, sir.
Yeah. Right. So now let's get into sex therapy. Now, sex therapy itself is it's not one form. There are multiple forms. Though a lot of people try to refer to sex therapy as the initial researches on sexual intercourse and sexual health was actually done by two scientists called Masters and Johnson, who are quite famous for their sexual model. In fact, I think a TV show is also there in their name. They brought forward the idea of sex therapy, though sex therapy today has become much more acknowledged and goes beyond just what they call as sex therapy. So you could see some people referring to sex therapy to refer to the Masters and Johnson form of sex therapy also. But In today's conceptualization, sex therapy is an umbrella term for many techniques or certain clinical procedures used by healthcare professionals to manage and cure sexual dysfunctions. So we are talking about some sexual dysfunctions. Now, what should we call as sexual dysfunctions? When should we identify a you know a sexual process to be dysfunctional? So this naturally led to the questions of what is classified as functional also, right? Now, uh, what is the goal of doing a sex therapy? Remember that it is not only for treatment of sexual dysfunctions, it can also be used to improve your already existing sexual functioning, right? You may not have a sexual dysfunction such as, say, an erectile dysfunction or a vaginismus or dyspareunia. You may not have any such disorders, but you may find your sexual satisfaction to be low at some point, may find it as not so adequate, regular, routine. These ways in which you may start feeling a little less intimate with your partner. You may stop communicating about sex because it's a very personal aspect of the individual, right? I mean, you say individuals you sometimes may find it very embarrassing to talk about their sexual preferences, may also find it embarrassing to talk about discomfort in a sexual act, things like that. So communication sometimes gets stuck as a result of that. And as a result of that, an overall quality and effectiveness about sex itself can come down. In which case, sex therapy can just play the role of probably improving that functioning standard of the individuals. Second, of course, to treat sexual dysfunction such as premature ejaculation, erectile dysfunction, vaginismus. These are more into the clinical part also, right? Both are taken care by sex therapy. Right. Now let's look at dysfunctions as such, and when should we probably identify, or how should we probably identify the individuals who require sex therapy? For every individual who tend to have a problem with uh, sexual functioning, need not always immediately guarantee sex therapy. Remember that when we are talking about sex therapy, sex being an act of two individuals minimum, you have to consider when you're calling a patient for psychosexual counseling or sex therapy, we have to kind of divide the responsibility of the sexual functioning to all the individuals involved in the act. It is not something that you have to individually always do, right? And let me say that it is not always. Um, it's not necessary that individuals ideas or individuals attitude towards sex is never targeted. That is not what I mean, but you need to see whether it is the right time to call the partner also to the therapy room to conduct sex therapy, right? So you have to do a proper assessment and integration of information about their sexual functioning, right? You have to get the um, you know, um, you have to get some kind of information on how does their sexual act go. Now, their sexual act may involve not just probably 20-30 minutes of activity. It can involve things that are the psychosexual context. Let me give you a very common problem that individuals tend to face in, say, especially in lower middle to lower socioeconomic status, joint families sometimes. What usually is the picture is that the couple may be staying with a series of people in the house, right? And privacy is very well compromised in a lot of situations, right? Um, 10 individuals living in, say, in a three-bedroom house, there is very less chances for privacy for individuals to engage in sex. Now, this is not something that is just directly going to come into play only at the time of the sexual act. This is something that you have to take care uh, before the act itself, right? So you have to assess things starting from there. What is the time in which couple engage in sex? Many times you see individuals kind of coming back from strenuous physical work, and then at night after everybody is asleep, and there is like, probably there is a child also involved in between, so child has to sleep, everybody has to sleep. This is probably late night, 11:30, 12 o'clock. The individual is also tired after such a strenuous long day. This is not a good setting to probably have sex with, right? So in that situation, it is probably the not right atmosphere, right environment for any such activities to happen. In which case, these also have to be quite well assessed. So, what's the time in which individual tends to have sex? What are the total family members in the house? Whether privacy is there? Now, whether how educated they are about sexual information. It is fascinating sometimes to look at how misinformed individuals are about sex because of the very fact that nobody talks about it, right? It is a taboo talking about it at home, taboo talking about it at the school with friends. If teachers used to find small kids talking about sex, it is immediately reprimanded, isn't it? So talks about sex is never encouraged, because of which there is a fair amount of misinformation and irrational ideas about sex also, right? All this have to be assessed. Individuals' history with romantic partners, dating history, individuals' premarital history, and if it is a married relationship, how was the courtship? What was the level of sexual intimacy during the courtship period? All these have to be well assessed. Even minor things such as whether the couple are completely removing each of their clothes, or whether they are that they remain half dressed and things like that. These are also important information because whether we need to make sure that the sexual environment has enough erotic cues, right? You cannot probably function well in a sexual setting that does not have any erotic cues, right? Something that in a layman language, you talk about turning on, right? If you don't have any such cues, then it's very difficult to engage in sexual activity. So all this have to be assessed in the beginning, and then probably look at certain medical indications also. For example, diabetes is a very common problem, because of which individuals over time tend to have peripheral neuropathy, which means that the nerve endings tend to lose sensations, lose the amount of sensitivity, because of which sometimes their um, sexual performance also gets affected, because their overall sensitivity of the nerves in their genitalia may also be limited. If such medical indications are there, then medical stabilization is first indicated, right? Now, it could also be that one partner has a sexual problem, in which case you may just counsel the individual first, then probably take the couple, and then go move into sex therapy. That's also possible. It is also possible to find a long-standing couple issue, right? For example, uh, blame games within couples, difficulty adjusting with the partners' families, partners' environments, difficulty with or dissatisfaction in their married life. These situations can often kind of destroy a good sexual environment also. So, in which case, sexual functioning might only be a manifestation of a lot of other issues that the couple may have. So in which case, you have to first take the couple for couple therapy, and once the issues are sorted, then move into sex therapy, rather than prematurely moving into sex therapy, right? Uh, if you have to also evaluate about individual substance use also, right? For example, substance use and sex tend to have a lot of relationship. For example, many individuals who may have performance anxiety in sex might uh, try to take in alcohol, or try to engage in, say, any sort of substance use, so that they can feel a little confident. But it may not be exactly working the way they expect it to, because obviously these are not medications for sexual problems, but individuals try to self-medicate many times also. right? So you have to see over time whether any substance abuse is there. You can also see substance abuse problems and um, sexual fidelity. For example, alcohol over a period of usage tend to have a lot of relationship with individuals developing fear of the partner being loyal, because of which we constantly hear about news of domestic violence and alcoholism causing domestic violence, uh, which also definitely leads to unhealthy sexual environments, marital rapes. These are all real issues that can happen because of substance abuse, in which case this abuse and this dependence have to be treated, after which couples have to be held for a while and then move into sex therapy. If it is just sexual problems only, there are no other problems indicated, then you can directly move into sex therapy, right? So remember this flowchart on when is sex therapy indicated. Depending on the problem is the answer, right? There is no hard and fast rule, but you need to first do a good assessment so that you can identify the problem areas, then accordingly decide when to deliver sex therapy, right? Now, we are talking about sexual responses. We're talking about individuals and their sexual responses. You are not always sexually aroused. There are certain situations, fantasies, thoughts, or real life situations where you tend to get sexually aroused. Now, in 1966, Masters and Johnson went out to really learn what is the cycle. How do individuals respond to sex? Now, they came up with this theory about five basic stages of the human sexual response. The first stage is the arousal stage. So, what happens in arousal? What are certain biological changes that can happen during sexual arousal? It may be different for males and females. It may be different, but what are the common things that you can probably think of when someone is getting aroused sexually?
Erection, increased blood flow to genitals.
Correct, correct. Uh, Genitalia may change their forms. It is definitely possible to get an erection. In females, it is possible to for some sort of lubrication around their genitalia. Also, it's possible in terms of liquids. There may be constant emission of liquids also getting ready as part of the sexual response. Your overall blood flow, your breathing patterns also sort of change, right? An increased blood flow towards the genitalia is also observed during the arousal phase, right? And this usually is the first stage when, as soon as a trigger is there in the environment, the arousal stage individuals get into very fast. Now, this is followed by a plateau, right? A plateau is a phase or is a peak, is the sexual excitement peak that you could get. Now, it depends on how the individual responds to the arousal, will determine how you are taken to the plateau, right? If it is probably self-stimulated, if it is partner-stimulated, or if it is, actually engaging in intercourse, or if it is just fantasy itself, sometimes may take individuals to the plateau, which is considered to be the peak of the uh, peak of the pleasure, right? Where you constantly increase the amount of pleasure that you feel, and then you reach an area where it is inevitable, right? For example, for men, it may be a phase at which they face the point called uh, ejaculatory inevitability, that it is not possible to um, not ejaculate at that point of time, right? That may be a plateau situation. Now, for females also, there are points of excitement and the peak of excitement that they face, beyond which there is an orgasm, right? And what is an orgasm? Orgasm simply means constant contractions and relaxation of your genital muscles. Now, this can depend on depending on whether it is a penis or a vagina. the muscles could contract and relax as a part of orgasm. Now, there is a slight difference between um, how men feel ejaculations or orgasms to how females may feel orgasmic, right? Male orgasms are usually considered to be one peak phenomena, while female orgasms are usually considered to be multiple peakings, right? Now, this is followed by a resolution phase where the peak hits, goes downhill, right? After the orgasm, the peak kind of goes downhill. Remember that resolution phase again for men and women are two different things. Resolution phase for men may be longer, it may last a longer period of time, while for females, resolution phase may be shorter. Um, they may able to get back into the refractory period, right? Get back from the refractory period to a next arousal faster than males. So this way it is quite different between males and females. And this was actually one of the primary criticism of this model also. Remember that this was the first time that anybody actually took an effort to study something about this topic. Until then it was strongly not okay to talk about it. But the biggest criticism of this model was that this model kind of represents men more than women, right? And that was a major criticism that Masters and Johnson faced, though they claim that women's response cycle is not so different. It's just that the time duration between resolution to refractory period, that is the time taken to reach back the arousal, is just different. That's all Masters and Johnson claim. But definitely, individuals and scientists were not happy with that fact. Because of which, just look at the time gap here. Johnson and Masters' thesis came in 1966, and it took almost 34 years for a sexual model that is more applicable to women to come up. It took almost 34 years because because it has to fight a lot of stigma to get a research on this published, isn't it? So Basson in 2000 came up with a model that could probably explain female sexual response cycle itself. Now, what Basson suggested is that for females, especially, it is not that it is not just about a sexual desire and arousal, but it has to be combined with emotional and physical satisfaction and along with emotional intimacy. Now, because of this, a sexual stimuli is given more attention to, and this leads to more arousal, right? So, whenever individual may be in sexually neutral situation, but individuals sort of seek certain sexually erotic stimuli, and once the stimuli is attained, they start feeling the arousal, they start feeling the desire, and once you engage uh, in this sexually um, uh, desired behaviors, then it leads to an emotional and physical satisfaction to the goal of emotional intimacy also. Now, this was a more intimacy based sexual response cycle that Basson had come up with. This also was met with a bunch of criticism because, uh, by this time there were more awareness about sex and gender. In fact, uh, many claim that it may not be as different between, for males and females. It need not be so different also, that men could also be seeking emotional intimacy and females could also be purely seeking sexual pleasure also. So the criticism for this model also had its fair share, basically. So these are two common models about what is a human sexual response cycle. Now, since we're talking about sexual dysfunctions, also another question that kept on coming up in individuals and scientists, where if we are calling a sexual functioning as dysfunctional, a sexual act as dysfunctional, we also probably need to define what is a good functional sexual relationship, right? Without that, we cannot really call something dysfunctional. Now, here on your slide, you can find two different sections. Is there any doubt? Someone has unmuted, I think. Is there any doubt? No.
No, sir.
All right. So if you look at the sexual act by itself, you may have to define between what is actually considered to be a functional sexual act and what is considered to be a dysfunctional one, right? If you look at the left side, that's a functional loops, or we can call it positive feedback loops, because the loop over the functional system is something that leads the individual to approach sex more, right? Which means that approaching sex is not necessarily a scary situation. It is not necessarily a situation that could bring in a lot of anxiety and a lot of upsetting emotions. Rather, individual feels motivated to engage in sex. That is what you call as a functional feedback loop or a positive feedback loop. So it has positive effect. There are positive expectations. Uh, Individuals are correctly able to identify how aroused they are. They feel well and good in control of their sexual, arousal. Also, that is a positive effect that usually individuals tend to have with a functional sexual life. They also tend to have a good amount of attentional focus, right? Now, it is very important that attention is a very important thing in sexual activity. I'll tell you why. Um, Let me give you this example. Uh, you know, there have been situations where, uh, most common problem that is seen in sexual dysfunction is something of a performance anxiety, right? You are constantly uh, doubting whether you will be able to perform in the activity itself. This is mostly the last factor before the sexual dysfunction happens is performance anxiety. So you are in the context, you are in the situation, you are probably engaging in the sexual act, but where is your attention focused on? Your attention is focused on anything but erotic, right? Not at all focused on anything that could potentially be classified as a sexual or an erotic signal. Rather, your attention is about your tendency to fail in a sexual act, or your tendency to probably not uh, being able to satisfy the partner, right? um, Sometimes couples have come with late marriage, especially in couples who have late marriage. Sometimes what happens is that there's a lot of societal pressure on to procreate, to reproduce, make children, because you're already 45 and she's already 38. You guys need to think about future life and children. And because of this, performance in the sexual act is sometimes so anxiety provoking for individuals that they are not focused on anything that could potentially turn them on bed. So your attentional focus is somewhere else completely, though you're physically in the environment. Now, because of this, what happens is that attention becomes a very key or plays a lot of role in the whole sexual act itself. Now, because of which your efficiency, your autonomic arousal, you guys know what autonomic arousal is? What is autonomic arousal? Autonomic arousal, you guys know about fight or flight mechanisms, right? So whenever individuals tend to face a threatening situation, they tend to wonder whether to fight it or flight, right? Whether I have to approach the problem or run away from the problem, right? So, whenever individual faces a situation where there is a demand for fight or flight, your autonomic nervous system will get active. Now, it's important that your autonomic nervous system gets active to an extent so that you are prepared for your body movements and prepared for your, overall physiological functioning. Now, in a positive loop, this is a very efficient system. It leads to adequate arousal. Your attention is also there in the erotic matters, and you have quite a good experience of sex, right? This motivates the individuals to engage in sex more. Now let's focus on the right side. What happens in a dysfunctional situation? In dysfunctional situations, there are unrealistic expectations, right? And you are not very sure of your arousal. Let me give you an example. A lot of men tend to think that um, individuals, men should always be ready for sex. There is some sort of understanding among a lot of men that men should should be ready for sex. If you are not responding to a sexual cue, then there is something wrong. You know, and because of this, a lot of individuals tend to inaccurately report arousal, even when they are not aroused. Sometimes individuals may feel pressure to engage in the sexual activity because of these beliefs like this, right? But these are not true, right? These are wrong and irrational, right? So with these wrong ideas, individuals tend to report arousal differently. Also, they feel that they lack control, right? uh, there have been situations where men, in the fear of difficulties in to face the sexual encounter, they start coming home very late. you know they start trying to avoid, because sex is so anxiety provoking, right? So they stop coming home, they complain of feeling tired, and they just go off to sleep. Now these kind of situations may happen because you tend to you the whole sexual activity is very anxiety provoking. In which case your attention is not really on erotic things, but is on the consequences of not having sex or not performing properly, right? So you start fearing whether, if I do not, if I do not attain an erection today, it means that more criticism from family on not making children, more concern from people asking me to go to the doctor, more pressure from families, more pressure from friends, they tease me, right? So these are the consequences where your mind is in which case your sexual performance is going to get affected, right? So this leads to a poor efficiency in working or in your performance or sex, because of your attention focus on the consequences, and it leads to dysfunctional performance, right? So on the left side, you find a positive way of approaching sexual encounters. On the right side, you look at actions that leads to higher tendencies to avoid sexual performance. Any doubts in this model? Anything you guys want to clarify before I move ahead?
Yes, sir.
Yes, sir.
Yeah, yeah. Go ahead. Ask. Am I audible?
Yes, sir.
Yes, sir.
Are you saying you have a doubt? Or are you saying that I can move ahead?
You can move ahead, sir.
All right. Fine. Right. Now let's look at some of the most common sexual dysfunctions. These are not all of them, but statistically or on a prevalent basis, what are a few sexual dysfunctions that are existing currently? This is just a brief overview about that. Um, a very common men's sexual dysfunction are slightly different from women's sexual dysfunction because of the biological differences also. Main dysfunctions for men, primarily it is of erectile dysfunction and premature ejaculation. These two are very common among men. Erectile dysfunction is an inability of male to attain or maintain an erection. Sometimes it is also possible that the male gets an erection, but male cannot sustain it for a long time. This is a very common issue that individuals tend to face. Another is of premature ejaculation, where individuals does not have a problem with getting an erection, but however, they with minimal stimulation, they tend to reach the orgasm phase faster, right? Because of which there is no time duration. Usually, the partner is left dissatisfied and not completely, uh, you know, enjoying the time or things like that. So, premature ejaculation can be a very dissatisfying experience also. Now, these two are very common among men. Now, for females, the most common issues are vaginismus and dyspareunia. Dyspareunia is also possible among men also, but by statistically, women tend to face more of dyspareunia. Now, vaginismus is a condition where there is involuntary muscle spasm of the vagina. Now, this can happen at various levels. Sometimes it is also possible that, in clinical settings at least, um, a gynecologist, OBG professional might be able to identify vaginismus earlier. When some women are called for examination by the gynec, sometimes their unwillingness to probably uh, you know uh, unwillingness to let themselves be examined and all that may be a sign of how apprehensive they are about their genitalia, about the spasms that they may get in case of a sexual intercourse. So these are usually a very common problem among women also. Another common problem is a painful sexual intercourse because of inadequate arousal sometimes. The whole intercourse itself can get extremely painful, because of which uh, you start developing a dysfunctional attitude towards sex also. This can be a very debilitating condition as well. Another problem is anorgasmia. Again, this is more common among females than males. An inability to really pay attention to erotic cues and probably experience the orgasm during the act. This is a very common problem among women. A common problem that is experienced equally by men and women alike is inadequate arousal. Whenever you see an individual with inadequate arousal, then you also may need to consider the possibility that individuals can be going through situations such as depression. For example, disorders such as depression usually comes with a diminishing of your sexual drive also, right? So you may not really feel quite enthusiastic about having sexual intercourse or about sexual acts, in which case you may have a hyperarousal secondary to that. So hyperarousal, hyper means more, hypo means low, right? So hyperarousal means arousal below required levels. This could also be a common sexual dysfunction. So how you target these problems will differ according to what is the sort of disorder. Some other disorders that you can probably read about, which is beyond the scope of this presentation today, is retrograde ejaculation, retarded ejaculation, and various paraphilias, like some of the deviancies that we discussed also are considered to be sexual dysfunctions, right? So you can read up on these in detail later. Now let's talk about how to approach this whole thing, because I think the syllabus that was shared with me also had a lot of information about how to go about counseling, what are the prerequisites of a counselor, and how should someone approach a case of sexual dysfunction or dissatisfaction. Now, something that is very often discussed about is the PLISSIT model, right? Now, PLISSIT is acronym for permission, limited information, specific suggestion, and intensive therapy. Now, when you're talking about permission, it is it is a way in which you try to make the individual feel as comfortable as possible with talking about sex, right? Now, there's a funny experience that I can share with you about my first experience of taking a sexual history. This is your initial training period, and one time a patient came and he said that he needs to speak to a male particularly, and then I was the only PG that time that I was available, and I was given the case. And I was asked by the supervisor to kind of, just, take some information about their sexual act and things like that. So I got the headings and all of that, but, this is the first time I'm taking a sexual history of someone. So definitely anxiety is there, because, you are not so used to talking about sex with someone who's, a stranger, you don't know much, right? So I sat with the patient, and then I started asking questions one by one. I didn't notice then, but now when I think back, I think I was not giving proper eye contact. I was guarded. I was using very gentle words, not using the words that are usually can be more communicative than these other words. And then what happened is that time went on like that, and finally, I think my supervisor sent my senior to just check up on me, what is he doing. And then my senior came up, and he came and he's like, okay, so you're writing history, right? And then he just brushed me aside onto the side, and he came and sat. And then he started asking questions one by one. Started asking in a very comfortable language, in a very comfortable language. Started asking about the time at which they have sex, how much time they spend in foreplay, what all they do in foreplay. And the moment he broke the guard, the patient was completely fine. It completely seemed like a different patient. So sometimes how guarded you are about this is going to influence how permitted it is to talk for the individuals also, right? So you need to probably make sure that's a very permissive environment for the individual to talk about it so that they can speak up. You also need to give limited information. We are not talking about a preaching session on sex. That is not what is required. We need to give the specific information that they may benefit from and has to identify that, right? So that problem has to be identified, and sometimes it's important to only give that information. Individuals may have their own preferences, their own ways in which they think sex should be conducted. That's okay. So you need to identify what is the exact information that they are lacking, because of which they are engaging in a dysfunctional sexual behavior. And based on that, you also may have to give a specific suggestion that sometimes maybe you could try a little differently. Maybe you can try with, lights on. Maybe you can try with engaging some games in between. Maybe you can try with, simple situations such as disgust and aversion towards genitalia or sexual activities can be simply sorted out with uh, taking a shower before sex. A specific suggestion like that could probably resolve their entire sexual problems also. So you need to probably be very specific about suggestion, and you also need to do intensive psychotherapy with deep underlying problems also. For example, many attitudes about sex are actually formed very early, right? With experiences within their family. Say sometimes it can also happen that sexual preferences change, or sexual preferences are different due to early experiences of abuse sometimes, concepts about gender, ideas about, sex and gender. Sometimes it can be about how married relationships should work. These are pretty early learnings, right? So sometimes it's very important for the therapist to uh, do a little bit of insight oriented intensive psychotherapy to address these deeper problems also. So this is what we call as the implicit model. Now let's also discuss some basic principles that you can use in treatment. Is there any doubt so far? I've been talking for almost 1 hour, so maybe I can give some 5 minutes for you to clear some problems or any doubts or anything.
Yes, sir. So this is more related to clinical part, right? Would you be coming to us counselors also how we could deal?
Implicit model need not necessarily mean only for clinical factors, actually. Even if you're a counselor, you would have to definitely target these informations itself, right? How different is it going to be? Just that maybe within the counseling setting, you may not be directly leading with disorders itself, but even in matters like, say, decreased sexual satisfaction, don't you think there may be certain information, certain irrationalities that they may have, which as counselors you guys can also take care of? Do you think it's that different? Unless there is a clinically diagnosed issue, definitely. But even without that, implicit model applies regardless. Why do you think it's different? Hello?
Yes, sir.
Yeah, but may I know why you think it could be different?
So I think when it comes to more about, as you said, disorders or the sexual dysfunctions which need to be dealt with, I think that would be coming under clinical, I feel. But yeah, when it comes to probably, as you said, dealing with probably understanding what is their level of understanding about sexuality, or what are the beliefs that they might have, I think that would come under counseling part, I think.
Definitely, yeah. So about the information that you may have to give about the um, definitely. See, I think one section that is also part of your syllabus and something that I have added in this presentation also is about rational emotive therapy for sex therapy, right? Which is which will also address these irrationalities. So even if you are doing psychosexual counseling, it does not mean that these models don't come into use. It simply means that the population that you may see is probably not diagnosed with a clinical disorder as such, but maybe having some sort of a marital issue or part of a dissatisfied sex life or that is getting manifested. In which cases also these models will apply the same. If you actually read about the now in this 21st century, what is coming up more is the relationship between cognitions and uh, sexuality, right? Which we will cover in the coming PowerPoint presentation also. But you also need to read about, say, things like dysfunctional beliefs, right? So in my introduction, I don't know if you noticed that one of my research interests is on sexual narcissism, and what I had also read up about during that time is a bunch of dysfunctional beliefs that men and women tend to have about sex. Um, for a lot of men, for example, it is a big fear that the female may be more dominant than the male on bed. This causes a lot of anxiety. Or for a lot of men, it may be a belief that um, having sex successfully implicates that I am a man. Some sort of a macho belief, if you could call. And um, yeah, some men also tend to look at females as um, potential people, sex as a distraction, or sex could be a distraction, and having sex regularly would stop me from achieving my life goals. These are all beliefs that actually exist. Actually, some of us may be finding it what so irrational when you hear it itself, right? But you'd be quite surprised into seeing how prevalent that is. In fact, I always wanted to see how prevalent are these sexual dysfunctional beliefs in India. If any of you want to take up like a project, you guys can actually. And how prevalent is it in rural populations and things like that. It'll be quite interesting. The um, misinformation is related to masturbation, for example. Very commonly, you find that in lower socioeconomic status individuals, especially, there is very little amount of information given on masturbation. For example, how many of you know about Thud syndrome? How many of you have heard about Thud syndrome? Has anyone heard of it? So there's a particular kind of a illness that actually exists only in India because of certain beliefs that masturbation leads to loss of blood. And when individuals in their early 20s, sometimes when they do not engage in masturbatory activities, and as a natural process, they may have, wet dreams or night falls, because of which they may have ejaculations in between dreams. And they tend to fear that they're losing blood, and they start feeling tired. They start having somatic symptoms secondary to that. That is how misinformed our country can be about about sexual activity. So these are all even without clinical implications, these information will remain. Right now, going ahead. Yeah.
So I have a question. So for males, orgasm is often characterized by physical phenomena of ejaculation. So, as a therapist, how would you identify if a woman isn't orgasming, or what are the physical or physiological or biological ways that you can identify that? Because there's no isn't as ejaculation.
No. There is definitely more amount of genital fluids that are definitely released during orgasm. It is not like there are no fluids that are released during a female orgasm. Typically, physiologically, if you have a contraction or successive contraction, then relaxations of your genitalia that can be classified as an orgasm. Now, female orgasm is definitely a very understudied area, if I can safely say that, because of again the taboos associated and a lot of stigma associated with understudied area. But a lot of conceptualizations are coming up and saying that it's actually related to mostly all women are possibly capable of getting an orgasm. However, attention towards the orgasmic feelings may differ between individual to individual, and this also again may root back into the socio-cultural environment. Uh, for example, females are very often taught at an early age to kind of, be regulated, be controlled, and not to indulge in sexual preferences and things like that. These are early some learning sometimes society also inculcates, because of which a lot of guilt. Yeah, a lot of studies are also coming up with guilt associated with sexual intercourse also. That engaging in sex is not wrong. In fact, something that sometimes as counselors you guys may also need to do is to probably involve a religious person, someone who a stakeholder of a religion or their community leader, someone of that sort, educating, intervening into the problem and probably educating the patient about um, you know the religious aspects of it also. Sometimes that's also needed. You will find like if the woman does pay attention and enjoy sex, they may also it may also get associated to the guilt that they may face, so because of which the pleasure itself goes down. So technically, biologically, there is a very good chance that um all females may have contraction and relaxations, but whether that sensation comes across as pleasure or is it going to get conditioned to guilt, that is a question actually. So you can read a studies. I don't think there's any conclusive answer to that, but usually physically many of them are capable. Attention and difficult. Yeah. So liquids may be released. Biological changes occur most.
I have a question,
Yeah.
sir. Is sexual dysfunction is anyway connected with the age, or dysfunction can happen even just after one come to the maturity age? Because there is a myth with the age, the dysfunction increases. What do you think?
Dysfunction can come with age, maybe taking it a little far. Okay. However, the time that you spend on sexual fantasies, the amount of stimulation that is required for one to be sexually aroused, okay, your overall interest and orientation towards sexual activities, your um drive may differ according to age. This has been confirmed and studied very well. Okay, for example, um, once menopause is attained for a lot of females, right around between 40 once that is attained, there may be hormonal changes because of which the overall drive may be less. This does not mean that sexual dysfunction occurs at that point of time, but maybe you could safely say that, yeah, depending on the age, individuals may be more vulnerable to get a sexual dysfunction. That is probably safe to say. Uh, Even among men for that matter, teenagers usually tend to be extremely responsive to erotic cues. Even a small thought, a fantasy about something sexual is enough for them to get aroused, right? But obviously, as you age, your drive may not be as much, as you were in probably in teenage and adolescence. Same with females also, it may not be as um, easy to get or that quick to get a erotic response sometimes. All those changes are possible with age. It is not wrong. However, saying that dysfunction can uh, uh, dysfunction occurs with age, it is not a direct causation, right? It's not a direct causation. With age, with changing biology, with changing, you know, sexual response, you could be more vulnerable to sexual dysfunctions at various points of time, right? That is true.
Thank you.
And also, it is also about, as you age, about the comorbid conditions that you also tend to get actually. For example, diabetes, as we already discussed, right? Significantly brings down your, sexual health. Actually, exercise, sleep, all these things goes for a toss as you enter, older age. At that point of time, definitely your energy levels come down. At this point of time, your sexual activities may differ. Okay, let's move ahead. Otherwise, we won't get any time to discuss a few basic principles in treatment. Right. One thing, as I already told you, is about mutual responsibility. Regardless of whether it's a male or female coming to you with a sexual dysfunction or a sexual dissatisfaction, you definitely need to make sure that the therapy or the counseling part is not simply done always with an individual. At many points in your sexual or psychological intervention for sexual problems, you may have to reassure, educate, and definitely change the blame to responsibility. Very often it is seen among couples that when one person if one person is facing a problem, usually the blame game starts, that it is your problem that we are not having children, or your problem that you're not conceiving, or we are not having, you're not able to perform sexually, right? Now this blame has to be divided, and rather the responsibility has to be put on to both the partners to kind of improve their sexual health. So mutual responsibility is very important in psychosexual counseling or sex therapy. If there are deeper struggles, if there are issues that goes beyond sexual problems, then a marital therapy or a couple therapy may be indicated before you move ahead with sex therapy. Another is information and education. We already talked about the importance of the right information to be provided. This may involve reading materials or educational films. Sometimes about even pornographic material may be required sometimes to educate the individuals about the anatomy sometimes, or sometimes about the process of doing something, say positions, about information about techniques, about how to do foreplay. Many times it is important to give information that it's important to build that kind of a desire, right? So you may also have to educate the individual about biology and sexual response cycle also before or during the course of treatment. You also have to try and get the attitude to be different. Individuals' attitude towards sex can play a big role in their sexual satisfaction. So a lot of anxiety and disgust on sexual matters usually come with a lot of negative attitude towards it, such as, you know, like I told you, one example that I had given before is about guilt associated to engaging in sex. Sometimes religion can be the cause of such guilt. In which case, involving a representative from the religious community to clear these negative ideas for better communication from the partner, you can involve people also, right? With consent, of course. With consent, addressing their guilt, you can probably do that so that you can try to change this attitude. You can use these cognitive methods, the RET method that we are going to discuss today. We can use that also to address this change. Like, is it really necessary that you have to be aroused all the time? Is it really necessary that you become some less of a man if you are not able to function well on bed? Is that true? You could probably try and challenge these attitudes also, right? Performance anxiety, as I said, is probably almost all the disorders in or dissatisfaction in sexual concerns usually precedes is preceded by a performance anxiety, a sheer level of worry or apprehension about engaging in sex. And many people tend to have idea that sex is related to erection, sex is related to penetration, sex is related to orgasm or ejaculation. So this become what happens as a result of these ideas is that sex becomes very goal centered. As in, you're not engaging the process. The whole point of having sex becomes the for erection or orgasm or ejaculation. That is not true, right? Because of which there's a lot of anxiety. When the individual goes onto the bed, only they are probably worried about whether they'll get an orgasm, whether they'll get an erection, you know, and this becomes a reason for you for someone to get performance anxiety. So rather than this, we have to help them focus on to the entire process rather than just the goal at the end of the day. Increasing communication is very important. Sometimes what you can probably do is that you'll be able to find, take this inventory, for example. I think it's called sexual interest inventory or sexual preference inventory, one of them, which has a list of different sexual fantasies which could be there. Sometimes what we ask the individuals to do is that we make the husband sit in one room, wife sit in another room, and then we give this inventory and we ask them to fill the fantasies, and then we keep the records folded, and then we call both of them to the therapy room, and we ask each other on what the other person's fantasies are, and we show how accurate they are or how inaccurate they are. Mostly they are very inaccurate because communication hardly happens between two individuals on what they like within sex, right? So what is that? What is my partner liking? What is my partner not so comfortable about? These things are hardly communicated. So one goal of your treatment should be to increase this communication and let the couple be in an effective way of non-threatening communication. Yeah. Another funny instance that I can share with you guys about threatening communication. A very educated family, a couple that was saying me, um, what had happened is that this individual used to have the husband had difficulties in attaining the erection, right? Now what used to happen is that during the sexual encounter time, he's definitely having that performance anxiety before they are engaging in the act, and he's constantly monitoring whether he gets an erection at this point of time. And sometimes what he tried doing is that he would go inside the washroom and then probably fantasize about something else that is erotic, so that he gets an erection, and then he gets out of the bathroom and then he communicates his readiness to have sex, and then the wife says that no, you did not get this erection fantasizing about us, this is something else, so we are not going to have sex. Just imagine how threatening that situation is, isn't it? So this kind of ineffective threatening communication definitely builds in a lot more incompetence and lack of capability in the individual, right? So this communication should be dealt with. Destructive sex roles and lifestyle. Lifestyle such as smoking, drinking, different use of drugs, very stimulation-seeking kind of lifestyle is usually not so great for your sex life also. You can also, your lifestyle may be in such a way that you may be spending large amount of time at work, but you are probably satisfied sexually at home, right? So destructive lifestyles sometimes keep sex as the lowest priority. So when they come to you for counseling and therapy, you always communicate to them that, the fact that you guys are here communicates to me that you guys are taking this whole thing into a bigger priority than something that you guys don't need, and that commitment is supposed to be there throughout, right? That they keep their sexual health also as one of the top priorities. So taking up certain collective responsibilities to step out of these traditional roles of sex about dominance, submission, who has the power, who has the loyalty, all these sexual roles should be questioned. So this also helps in treatment. And something like in the specific suggestion part of Plicit, it's very important for the counselor or the therapist to prescribe the exact change in behavior that you are identifying that is leading to the problem, right? Like I told you, sometimes it's about keeping the lights on. Yeah. Do you think it's important to keep lights on during sexual intercourse? Can we have a discussion? Is it necessary or is it not necessary?
Sir, I believe it goes on the level of comfort,
Yeah.
personal
Comfort.
preferences,
Yeah.
choices.
Yeah. Now, are there any men in the group, by the way? Half of all of our uh, audience today, are they females? Is there anyone who identify as males? Right. Fine.
I think there's one male, sir, Vishant Menezes.
It's definitely mostly onto the minority here, right? But basically, why I asked for that is it is definitely shown in
Sir, sir, two are there, two male
that's okay.
participants.
That's
Okay,
okay. That's
alright.
my target. I want to take it.
It's okay, okay.
Yeah.
Yes, sir, I'm here. What happened?
Nothing happened. I just wanted to hear from your side also whether you think it is important to keep lights on during a sexual activity or not.
I I think it depends on the comfort levels, honestly, or
Yeah.
maybe if you're not that experienced, I
Right,
guess.
right. Now, a very simple logic that usually we need to keep in mind is that we are talking about attention to erotic cues, isn't it? We are talking about attention to erotic cues, and according to the cycles, the models that we saw, individuals can get conditioned to various different erotic cues. Some what one may find as erotic may not be what the other person finds as erotic. Now remember that some sensations such as touch and the warmth and all these tactile sensations definitely does not require light, right? But a lot of visual cues on the other hand requires a lot of light. You need to see what is happening so that you get eroticized. So this why I asked for males and females because consistently studies have shown that males usually get quite uh, aroused with visual cues. Yeah. And tactile is common for both, but males have a significantly higher tendency to get turned on or get aroused with the visual cues, because of which we always suggest the couples to keep the light on, right? Because otherwise it is you may not pay attention to a lot of erotic cues around it, right? So these specific changes in behavior have to be taught to them or suggested to them. Some commonly used techniques also we can talk about. One is the sensate focus. Now, sensate focus is the initial therapy form that was brought down by Masters and Johnson. This is a counseling method which involves couples to probably start paying more attention to the sensations rather than the outcome, right? As we saw in the previous slide, sometimes the very idea of goal directedness in sexual activity itself is the problem. So we need to slowly change that attention to the sensations. So something that we usually do in sensate focus is that paradoxically, when individuals come for sexual counseling, what is the first thing that we say? We tell them, okay, anyway, it is not happening right now, isn't it? Right now, you guys are not really, happy about the sexual life that you're having. He is not attaining the erection, and all this is happening. So, how about this? We are not going to engage in sex for some time until and unless the therapist is or the counselor gives the green light. We are not going to engage in sex. Okay, so this is something that you can do in the first session so that you can make them start focusing on to the various other aspects of sexual life. So, one of my faculty used to say that, sexual act is like, watering a plant, right? It does not mean that, plant is probably the intercourse or anything, but it does not mean that the intercourse can happen without adequate atmosphere, the oxygen, the water. Without that, the plant cannot grow, right? So you have to actually set the environment into a much more conducive manner so that sexual activity takes place. A few things like we discussed about, finding a right time to have sexual activity is very important, especially after a child comes into the picture. Because once the child is there, sometimes, child is sleeping with you. Obviously, this is not an advisable period to have sexual activity next to the child. In fact, trust me, there have been cases where that has happened, right? And it is also possible that individuals keep the lights off, they engage in a hurried manner. Sometimes sex is very hurried, especially if the relationship is of illicit relationships in nature. Many times, individuals tend to have sex in a hurry so that, they can make sure that nobody finds out about it. In such cases, definitely you are not going to be focused and things like that. So what we do is that we ban sexual activity until a certain point in therapy, and we encourage the individuals to engage in the previous aspect. That does not necessarily mean only foreplay. This has in a particular case that we worked, something that has helped is that the partners used to take turns onto inviting for sex. Like, for example, there was this wife who used to iron the husband's shirt in the morning, and she used to secretively keep like a small note saying that today at 8 o'clock, we'll have sex or something. She would write a small message in the pocket, and husband randomly finds it in between the office, excites him, or vice versa. Husband leaves a note on the table before going for work, and wife gets up and sees the note. You know, these kind of situations are usually, or sometimes treasure hunt is being given. These kind of games and all. If you do, it usually spices up and usually excites the couple into kind of building the mood. About the sexual activity, and this goes on for a fairly long time. And we also advise that when they actually engage in sexual activity, you do not focus on penetration. Penetration is banned. Okay. Now, paradoxically, because of the very fact that the you are banning penetration, many individuals actually get the erection in the second or third time that they try, because it is not a cause of anxiety anymore. Erection is not a cause of anxiety anymore. So paradoxically, it works in their favor that they start getting erections. And it is very common that after third session, they drop out from therapy because they actually break the ban and they engage in the sexual intercourse and they stop coming for therapy also. That is also possible, okay, right? But nevertheless, whatever works for them, isn't it? So sensate focus involves banning penetration and not advising penetration until the environment is conducive and appropriate, right? So probably only by the third or fourth phase of sensate focus, you advise the couple to probably engage in penetration. But even there, we ask the individuals to do something called vaginal containment, which means that there is no to and fro motion, but the genitalia is probably penetrated and is left like that for some time, and then probably the fourth phase, the further to and fro rhythmic movements and all can be added in the last phase. So this is the usual focus or sensate focus. This is commonly helpful in multiple situations about sexual dissatisfaction, about goal orientation within sexual activities. All of those situations can be easily sought out through sensate focus. Stimulus control is also something that you can do, which means that some environmental stimuli that could be the reason for sexual dysfunctions, we ask them to kind of control. For example, say something like light or something like we can ask individuals to probably keep a lot of candles around, so that the mood is better. So if music is not too distractive, they can try music. They can make sure that they take a time that is most apt for sexual activity. Like probably if children are there in school, can the couple find a time when the children are in school rather than after they come back? Or is it possible to find a time early in the morning to probably engage in sex, right, rather than late at night? These are ways in which you can control some environmental stimulus that can help. Cognitive restructuring, like I already discussed, and something that we will again discuss about irrational thoughts, irrational ideas about sexual activities can be tackled. And start stop technique is also something. Start stop technique would include, it is primarily for premature ejaculation, because in premature ejaculations, men may ejaculate before the complete satisfaction, before the desired time, right? In which case, individuals can engage in the thrusting motion, but as the arousal gets too high, they immediately stop, or they can even engage in squeezing techniques of the penis so that they do not ejaculate. Uh, I'll show you some pictures also on the same. Now, another another way in which you can look at what is the difference between good sex and bad sex. If you look at, uh, in in bad sex, you have an identification of sex as some sort of a duty, as of especially in between people who believe that sex is only about procreation. You'll find that is more like a duty or some sort of a routine, that I have to satisfy my partner or I have to make children. But in more healthier sexual relationships, what you find is that there is a lot more desire. There is a lot more, uh, you know, uh, uh, I want you kind of a idea that actually is very suitable in sexual relationships. So in men, it is a lot about agency, is what where their ability to provide, their ability to be in control is usually very desirable for men, while for women, it is more desirable when they embrace their sexuality, they make a choice to show their sexuality, feel emotionally, physically, and sexually safe, is usually something that is seen more among women as desirable. And among men and women alike, emotional connection is definitely something that men and women look into to feel loved and cherished. These are characteristics of a desired, I want you kind of a sex rather than a duty sex, right? So, agency, connection, embracing the sexuality, and safety related to sexuality are, acronym of ACEs, is usually seen as a um, as four probably components that the counselor can take care of when you're talking about sexual satisfaction. Now, this is the start stop technique that I was talking about. In the start stop technique, you may engage in masturbation or sex with the partner, uh, where the stimulation usually builds up, and just about the time of climax, you leave all the stimulation. If it is masturbation, you leave the genitalia, or if it's sex, then stop the thrusting motion, and then you wait until the urge of ejaculation goes down, so that you can repeat the process. This is called start stop technique, usually used in premature ejaculation complaints. Now, some other techniques that we can discuss is about squeeze technique, in which case that I told you that it is sometimes it's also possible that the partner can squeeze the male genitalia so that the penis does not ejaculate, right? And this also sometimes from the tip, if you squeeze the penile organ, then the individual does not orgasm and does not reach the climax, in which case they can continue into the intercourse. This is also a technique. Kegel exercises, these are used for vaginismus, These are advised by clinicians or by counselors for improving their pelvic area and the health in pelvic area. Now, ideal way of giving Kegel exercise, let me see, there must be an right. This is a sample of a Kegel exercise. For females, it is possible to lie down and probably, uh, you know, uh, lift the pelvis from the floor, and this usually targets all the pelvic muscles, and usually this leads to a good control for pelvic area and vaginal contractions, relaxations. Usually, this is very helpful. Even men can do it. Men usually are advised to do in another way, not actually how it is shown in the picture, but men can also practice Kegel exercises by um, uh, simulating the same muscle motion as you would engage in when you want to probably hold your urine. Supposing that if you had to hold your urine, you would try to engage some muscle groups as a part of that, right? Same muscle groups, if you try to contract without, not when you have to urinate, but otherwise, if you try to contract, that is basically you are engaging in a Kegel exercise, right? For men also, having good pelvic health could mean a better foundation for erections to the erections may be healthier, and more control over their genital contractions and relaxation also will be there as part of Kegel exercises. So uh, this is advised by a lot of clinicians, and a lot of health instructors also instruct users to engage in this. Um, yeah. So this is more like the squeeze technique when the individual have to hold the glandular area in front of the tip of the penis. That area, if you are squeezing, then you can prevent from orgasming and reaching the climax earlier. And once the urge settles down, can continue with the process. This is called the squeeze technique. Now, some other orgasmic reconditioning is not a technique that is of at least relevance in counseling situations. Is definitely not something that is relevant. When individuals are not able to attain orgasm, um, making the individual pay more attention to orgasmic erotic cues is what happens in orgasmic reconditioning. It does not have a lot of evidence, also, to be honest. So, not very well used in settings. But relaxation techniques, on the other hand, is more used. In relaxation techniques, what you usually tend to do is to teach paired muscle relaxation, which will involve like breathing techniques or muscle contraction and muscle relaxation. Maybe paired muscle relaxation you can do, so that the individuals feel much more safer during session situations, especially when one of the partner is aversive, disgusted, or afraid of sexual activity. Employing relaxation techniques and probably slowly starting off with low anxiety provoking situations to higher ones can usually help the individual relax in sexual settings also, right? So relaxation techniques are very widely used. So these are some of the commonly used techniques. um, this is a sample treatment for anorgasmia, step-by-step procedure. That this is a sample just for you guys to get some clarity. In the step one, sometimes we ask the woman to visually examine the genitals. It's sometimes uh, possible that women may be aversive about their own genitals, and it can happen with men also, but probably more prevalent in women. And Kegel exercises are taught. Sometimes using a hand mirror, women are allowed or encouraged to examine their genitals, exploring their genitals with some pleasure sensitive areas. What are the areas where they feel pleasure? Whether and usually encouraged to, in step 4 and 5, you encourage the female to probably stimulate these areas with erotic fantasies, with literature, with photos if it is required, so that they can first identify themselves on what is the way that they like, right? And if orgasm is still not occurred, then probably in the step 6, the woman is encouraged to masturbate maybe using a vibrator or some sex device if it is required, then that is also used in the contemporary sex therapy practices. You also may encourage um, the partner to join this activity or wife's masturbation and identify what is effective for the female also. And then husband may be encouraged to identify how to manipulate the genitals in such a way that the female attains orgasm. And then this is paired with the sexual activity. So this is a sample treatment for anorgasmia that is used by sex therapists. Now, final part of your syllabus, something that I also had to read up a bit about, to be honest, is rational emotive therapy for sexual dysfunction. It is actually a growing source of literature, probably with the first information on rational emotive therapy for sexual dysfunction came from the developer of REBT himself. Who's that? Who's the developer of REBT? Anybody? Yeah, Albert
Albert
Ellis.
Ellis.
Yeah. Albert Ellis himself had a fair amount of knowledge working with patients with sexual dysfunction, and he himself had suggested that rational emotive therapy could be very beneficial. So, uh, you know, um, if you look at cognitive behavioral therapy and rational emotive therapy, that came around a similar timeline, but rational emotive therapy probably did not take as much public, what do you say, the prominence or marketing was not so great for REBT, not for the right reasons, primarily because of probably all the insurance agencies, trying to include psychological interventions as part of the insurance. So they wanted, like, CBT is the only treatment that we give insurance for because it is time, there is a little more time limitation in that, because of which a lot of therapies started getting included under CBT. But REBT, on the other hand, is also a very good therapy because it takes a very casual and rational approach towards things. And especially in the context of sexual dysfunction, such a casual, non guarded, a permissive kind of environment is usually very beneficial for addressing sexual problems. So, suggested by Ellis himself, identifying the irrational ideas about sex, and identifying and targeting them. Now, the recent research studies are showing that rational emotive approach to sexual dysfunctions have almost the same efficacy or same effectiveness as Masters and Johnson suggested in their sex therapy. So it is pretty good. Now, it will involve some cognitive works or thought related works about what information to be given. It has to be quite down to earth, casual information that has to be given, like suggested by the implicit model, right? You have to identify what exactly is this idea that the individual has about sex, right? So, sometimes imageries are given in terms of individuals try to be taught how to fantasize intensely. It is almost shocking for us to sometimes wonder that individuals who tend to engage in fantasies um, feel quite guilty about it also, especially at a adolescent age. Guilt related to masturbation is very common, actually, right? Guilt related to fantasizing, guilt related to masturbation is very common. It has a lot of analytical explanations also about it, because during the Oedipal phase, when individuals tend to have fantasies about sex, they fear that they are harming their mother object in a way. So they feel guilt associated to it, and they stop fantasizing. There have been cases of obsessive compulsive disorders being you know um, developed as a result of this guilt. These are common. So as part of cognitive work in REBT, many times you encourage the individual to have imaginations, to fantasize about sex. And two processes that you encourage the individual to do as much as possible is anti-awfulizing and anti-absolutizing. Some some part about sex may sound extremely awful, right? Such as, you know, my wife came to me and she told me about probably spending some private time together, and I was not in the mood. It's so awful, it's so bad. It's so bad that I'm not ready at that point of time. So from an RBT point of view, you would probably go ahead and question, and is it so? What is so bad about it? Is it really necessary that you have to be aroused every time that your wife makes advancement? Is it necessary? How could you have possibly, you know? So you draw that ABCE model on what happened right before it. What were the cognitions, such as uh, I have to be aroused every time. This becomes the antecedent thought. Because and then I just shied away saying that I'm so tired. And as a result, my wife was also upset. Then we slept facing opposite sides of the bed that day, right? So you identify these antecedent thoughts, and you target these catastrophizing, awfulizing, or absolutizing. Absolutizing means like drawing general conclusions that all men are okay with having sex whenever they want. That is simply not true. That's not an absolute truth, right? If you are talking about your friends telling you that they were ready all the time, well, it is very much possible that they could be giving you wrong information, right? So these absolute ideas, general ideas, awful ideas, they have to be probably dealt with in terms of appropriateness and badness. You also have to address the guilt in terms of addressing the shoulds and musts, right? Many times individuals tend to have that I should be the dominant one on bed. I must be able to satisfy my wife. If not, why am I even being called a man, right? I'm so bad that I cannot satisfy my wife. These are shoulds and musts that usually tend to have, individuals tend to have, right? That causes a lot of guilt, and guilt is definitely not a good situation to be in to engage in sexual activity. You also may sometimes give psychoeducational information through films, books, or like organized material. You may give pornographic materials and things like that may give to change these ideas about appropriateness and badness. Because technically in sex there is nothing that is absolutely appropriate, right? You also target emotive works. Their emotions may also be targeted by the very unconditional acceptance that is given by the therapist. When conducting a psychosexual counseling, anything that is related to sex is acceptable. And this is probably the only place where the couple feels so good about discussing this, because it is never agreed anywhere else. This actually challenges their emotions about appropriateness and everything within themselves. And sometimes what you do is that you attack the shame, right? Anxiety very often comes with shame. And also within sex itself, a lot of things individuals may find as very, shameful about may actually be erotic, right? This is also because sex is conditioned to shame in a lot of manner. Since childhood, if at all something appears on the TV and you're watching something with parents, there is immediately a coldness and there is an awkwardness, and you try to change the channel because it's so embarrassing. It is so shaming to sit and watch. And sometimes parents also contribute to this. If parents find a child with some pornographic material, right education is not given. Instead, sometimes child is shamed for it. That's also possible. So these shameful things that they identify sometimes may have to be attacked. Within their personal space, there may be slight, slight deviances that are acceptable on both parties. Of course, that has to be discussed between the couple. Not everything might be acceptable, but these things can be discussed, and behaviors that could attack the shame can be encouraged. You can also encourage the individual to take some risk-taking exercises also. For example, sometimes in terms of thrill and a time when you are a time or a setting which is not usually not so comfortable in sex, you can advise the individuals to probably engage in something like that. For example, say taking some amount of effort to probably book a hotel room outside Maybe is that okay? Like, if that involves a bit of risk. Is that probably possible between the couple? You can encourage them to do it. And you can also encourage the individuals to have emotive verbalizations, and you can also, as they give their emotions in terms of verbally or non-verbally, you can give the feedback also. I noticed that when you were talking about this, you are looking down, you are not giving me eye contact. It looks to me like you're quite embarrassed about this whole idea. You want to talk about it. You can give the feedbacks, and you can encourage them to verbalize as much as possible. These help in the emotional part of it. Some behavioral works in terms of giving homework assignments, specific suggestions. Today, you could probably go and, until we meet next week, 1 week time is there. Let's make sure that you guys take turns and invite each other for, and you set a time. You ask the partner about what time is best for tomorrow or today, okay? And then probably take turns and invite, leave a message or send an SMS or call and talk to them in secrecy. These are homework assignments that you could give. You could also give homework assignments to just engage in foreplay. For example, spend 40 minutes in foreplay. There's no need of penetration, right? And when they are actually engaging in behaviors that are conducive, you can ask the partners to reward each other in terms of verbally telling each other that, that thing that you did, I really liked it. Even therapists can sometimes reward the couple for being aligned with the homework and being aligned with the therapy goals. You can also train individuals to have some level of assertion also, right? In assertion, what you do is that if you are absolutely uncomfortable doing something and you have a valid reason, you can probably learn how to politely but assertively communicate to your partner that you're not okay with something. Okay? Or even if you are unhappy with something uh, that is not being done. For example, you as a partner may require, or you may feel that at least once in a week you could probably engage in sex. If that has not been happening, you should feel comfortable and confident in going to the partner and making that request that we haven't been doing it for the last 1 month, that it's worrying. Can we probably think of taking steps? Addressing it and asserting yourself is also necessary, right? So assertion training, all this comes under behavioral work. So rational, cognitive works, emotive works, behavior works, all of them are indicated in RET for sex therapy. Right, I guess that's all I have for today. We are reaching time also, but I guess I can take some extra time for addressing questions. If you have any queries about anything that we talked today, I will try to answer as much as within my capacity.
Okay, sir, I have a question.
Yeah.
So, for a male or a female who is continuously into masturbation and pornography, so will that affect emotionally or sexually in their married life?
Okay. My question to you would be, what do you mean throughout?
Throughout, in the sense, sort of, we will say like, oh, okay, a person is coming to us and saying like, I am addicted to pornography, or I am addicted to masturbation, like once in a day or twice in a day. So that's it.
The question would be, what is it that they're calling addiction? Because technically there is no normative number of times that one could masturbate in a day, right? There is no normative number. Many times, you hear patients asking you, how much is okay? The answer to that is, how much time do you have? I mean, if you are in a job, if you are in a school, if you are in a college, if you have daily works after your college or your daily duties, if you have homeworks, if you have assignments for the next day, if you have work for the next day, if you have to cook food, if you have to maintain house chores, how much time do you have, right? And within that time, how much ever it is okay, it's fine, all right? But if it is causing significant distress personally, then are you finding like a lack of control? Have you been trying to stop it and not being able to do so? That is a problem, right? Have you been not going to work because you want to masturbate? That is a problem. Have you been not engaging in sex and you have been avoiding sex and only engaging in masturbatory activity? That is also a problem. So you need to probably interview, explore further on what exactly is the patient identifying as a problem. Why do they think they are addicted? Right? These words has to be explored more. Now, coming to the other part of your question, is it going to cause problems? So let me tell you some of the scientific research evidence that we have. There is a controversial concept called the death grip. Okay, so death grip is mostly applicable to males. It is a concept that talks about excessive, uh, pressure in holding your genitals through, which may happen during excessive masturbation. You may lose some amount of sensitivity around your genitals. It's a theory. It is not very well evidence-based, scientifically validated concept. It is controversial, but these are certain things. It may you may also see that in people who engage in masturbation excessively, especially males. Again, what you could find is that there is no control of ejaculation. They reach pretty quickly without adequate erection. They reach from the plateau to the orgasm phase quickly. Now, this is also indicated in premature ejaculation. Now, it can happen the other way around also. People who haven't been masturbating at all, that can happen, in which case even slightest sensations on your genitals can cause hypersensitivity. In which case, counselor may actually advise the individual to probably use protection, or probably use double protection if necessary, so that sensitivity over the genitals is slightly reduced. That is also doable. Now, pornographic material. Now, that is the second part of your question. Pornographic material, these are not controlled by authentic sources, right? And pornographic material can have, it's a double-edged sword, right? On one hand, it can be very helpful in terms of educating, but pornographic materials can also be a lot of source for misinformation. It also may become like a coping for individuals who try to cope by stimulating themselves. Many people who are extremely stimulation seeking, excessively sensation seeking, may engage in like a constant preoccupied with porn, preoccupied with ideas in porn, may start choosing preferences and skills that are used in porn. Unrealistic expectations may also begin about the duration of sex and things like that that are usually shown in porn. This can become a problem. So my answer to you would be to explore what the individual is finding as addictive, right, and target accordingly. If the individual is talking about being addicted in terms of there is a lack of control that they feel about porn, then you could probably help the individual in educating about what are the possible effects of negative effects of watching excessive amount of porn. You could also probably help them in regulating the number of times that they watch, or probably limiting it of some sort, or addressing their irrational components. In fact, I would like all you guys to probably go and check out this questionnaire called Sexual Dysfunctional Beliefs Questionnaire. There's a male version and female version. The irrational beliefs that are associated, whether it has developed as a result of porn, you can just do that assessment to know, right? So you can address all of these separately. Did I answer your question?
Yeah. Thank you so much.
Considering that accurate knowledge is like basically very important, do you have any suggested reading material, both for us as therapists as well as things that you might give to a client, or accurate information sources, basically?
I think I will forward it through your coordinator. I will send across a book, which is one of the initial material given by Lo Piccolo. I would advise that many of you in the training phase, it may be important for all of us, because even I had to go through a lot of what do you say explorations about what has been your idea about this so far, right? So all of you guys also, I would definitely advise you guys to read through some of the works given by uh, this author called Lo Piccolo, Lopiccolo. Lo Piccolo was a pioneer in psychological interventions on sex. He gave initial works, most of the initial works about sexual history taking, or educational information about sex. A lot of them is given by Lo Piccolo. Later researchers named Anderson. Anderson is also a scientist who worked extensively in the field of sexual dysfunctions and cognitive uh, roots of sexual dysfunction. There are two Portugal scientists called, I think it's pronounced Nobre, Nobre, Nobre and Peterson. Nobre and Peterson, they have also been extensively working with sexual dysfunction. These are all materials that you can read up about understanding sex for yourself. No, these are not supposed to be given for client material. Client material, I usually choose material that I find authentic, and I sometimes prepare my own slides. I don't think you guys will be uh, able to use those. Rather than that, I would suggest you to make your own material. Why not? Addressing your own after reading and developing. There's a sheer dearth of all of this, to be honest. Okay, like if you Google something about sex right now, higher chances that pornographic things will come up, right? Which is definitely not advisable in because of a lot of reasons. So the dearth of all of this is there. So I would say that okay, maybe you guys can also start developing some material, informative materials, flyers. Maybe like your faculty can give you as a assignment that all of you develop like flyers for sexual information. Divide yourselves into groups and come up with a few flyers. Why not? Yeah, you can give it to clients and you can use that. I don't know about any authentic uh, information pamphlets. I may have to search for that. Yeah.
Sir, I have a question.
Yeah.
I'm currently a trainee counselor. So
Okay.
I had come across a case where the concern was that the individual was actually having a lot of trouble with regard to masturbation because he's very religious in nature, and
Right.
masturbation is not something which is very closely associated with something which is good. So he directly told me, to quote him, "This is a sin, I cannot masturbate."
Okay.
But this has been causing a lot of distress in other areas of his life and functionality.
How?
I had no option but to actually address him and tell him the benefits of masturbation. And I had to look up a lot of information with regard to how masturbation works in physically relieving stress and psychological benefits of it and all. But he was very, very firm on that end that he will never masturbate. And
Okay.
that
So
caused a lot of problems.
what is the
I
problem
couldn't.
that is caused because of that?
He had, I don't know if this is the right term, but he said he had blue balls and discomfort while sitting, inability to function properly, a lot of pain associated with the groin area, and all of that. There were no uh, physiological problems behind it, as in he is physically very fit and healthy. He also
Okay.
exercises often. But the
Okay.
only thing is, he chose not to masturbate because it's a sin, is what he
Okay.
said.
Yeah.
How do I tackle this?
Oh, first of all, why is the pain and all being caused? I mean, it is not very usual that just because you don't masturbate, there is a severe pain or anything. Blue balls also is a very layman concept. Individual does this person have wet dreams and things like that? Like fantasize? Is that okay?
Yes, sir. So this person was actually supposedly in a friary wanting to be a monk or a priest. So he
Okay.
quit that and he came back. That's why the beliefs are very firm. His core principles, I tried using CBT. His core principles and beliefs are very, very, very firm. What he told me specifically is that there is a lot of pain and there is nightfall and all of that.
Okay.
He he doesn't actually fantasize anything, but when he wakes up in the morning, he just feels that the particular area is wet, or he's very uncomfortable in his inner garments and all that. He says thoughts are very clean and does not fantasize anyone.
Okay, okay, okay. So if that process is also happening, night falls is sort of like an emptying mechanism of your body when you do not masturbate for too long and things like that. Old semen has to be uh, given out. So it's a normal body process which will happen. If that is also happening, then I would probably want to know what is the cause of the pain. You know, whether there is any physiological cause. I would probably send it to a urologist first and see if there is any sort of problem related to the physiological problem first. If that is also not there, then probably something that you have to encourage the individual to do is to fantasizing. I don't think any religion say wrong, or thoughts about sex is not necessarily seen by many religions as wrong. You can probably even get the help of someone who's probably, if this person was probably studying to be a monk, you know, uh, you can probably find a reliable individual who could probably help you out in the same religion, or religious representative, someone who might have dealt with fantasies. Look, fantasies and sexual thoughts are very common, whether you are part of a religious institution or whether you are part of a, you know, uh, any community. As an individual, you will tend to have thoughts or fantasies. On, I would want to know how is this person dealing with them, and I would probably include with the individual's consent to probably speak to a representative of the religion on how they probably dealt with it. Hmm? And if they probably reassure him that these are not necessarily absolute rules, uh, then maybe it is okay. Yeah, maybe like masturbation is not okay in terms of say some religions, but at the same time, fantasizing or sometimes having thoughts about sex is not wrong. And the more we condition it to saying wrong, the more the individual feels pain about it. My immediate question is whether this pain is related to the testicular area at all, or is the person just paying a lot of attention and is this psychosomatic in nature for all you know. So you need to evaluate all of that. You need to definitely evaluate all of that. The moment pain comes in, it is taken into a clinical setting actually. You immediately probably need to get a urologist screening done on saying that there is absolutely no problem with this, groin or its pelvic area. After that, probably we can narrow down into diagnosis of psychological causes behind it. Then individual may also start getting concerned. Okay, this is probably my mindset and my attitude towards it that could be the problem. After which you can probably educate them about masturbation, and you can probably involve a religious representative. All that can be done after that. So that should probably be the line of management, is what I think.
I have a question, sir.
Yeah.
Yeah, I'm as a psychotherapist. I deal with a lot of adolescent children. So I have a case where a 13 years boy, he has a habit of watching pornography and masturbating.
14
But
year old.
how? Yeah, how do I educate him? Tell him it is not the right age, or he should not be addicted to that, or is it a it is not affecting him in any other ways? I can just leave him.
Who had the problem with it? As in family had the problem with it.
Yeah, the parents are
Yeah.
having anxiety about it.
Um, where does okay? This is a child case. Okay. Now, when you're handling a child, there are a few things that you may want to take care of. One is that you don't want to tell the child that you don't want half information to the child saying that sex is wrong, right? That is not what you want to communicate. You also do not probably want to communicate that fantasizing is also wrong, or having sexual thoughts. And we are talking about age 14, when children are probably, these are normal reactions in terms of exploring their sexuality and things like that, isn't it? So uh, we need not really prohibit them from exploring and things like that. At the same time, parents may have their fair share of concern about introducing pornographic materials which may have its adverse effects, isn't it? So Probably something that is safe to do is for the parents to probably use, there are child lock mechanisms, there are ways in which you can restrict certain websites, or which are opportunities where this individual, uh, this child is getting access to pornographic material, can be limited, can be targeted, can be manipulated. At the same time, encouraging a healthy discussion about sex life, ideally from the same sex parent. Ideally from the same sex parent, probably encouraging a discussion about sexual explorations, about, potential changes in their body right now, potential, phenomenon. The number of women who are uh, traumatized because of the lack of preparation they have towards menarche, number of boys who are traumatized because of their first ejaculation are innumerable. You don't want your child to go through all of that. Instead of that, you can probably educate the child about what are healthy sex practices, what are healthy hygiene practices towards genitals. These are safe informations that you can give. No?
Yeah,
So these,
he's not having a fantasy or a night pulse, but masturbation is he's having it only when he's watching pornography. So
you are fantasizing even when you're watching.
yeah,
You are fantasizing even when you're watching. Even when you're watching, just because there is a visual aid does not mean that your fantasy life is nil. In fact, if your fantasy life is nil, then your masturbation is not going to happen. Visual information there is only serving as a aid to speed up your fantasy. Okay. Even without visual pornographic material, you can fantasize. And it is very common that children at the adolescent phase, they may engage in masturbation also. Your problem is with porn, no. So parents' problem is with porn, isn't it? So why don't we just target porn? Why do we have to limit their masturbation?
okay.
That would be my question. So that I would probably want to ask the parents also on what is the target. Are you talking about limiting them by masturbation, limiting them by fantasies, or limiting their pornography material? Because
They are worried watching pornography is not healthy, and masturbating at that age is uh, adequate or not.
mm, irrational. It is quite possible that individuals at the age of 13, 14 may start masturbating. It's the time when they are starting to explore. They may get information from their peer groups also that, okay, you can do like this, and then, this feeling happens. They may get information from friends. It is quite possible that 14-year-old, 15-year-old may be starting with, masturbation. Excessive amount of masturbation, disinhibited masturbation, are those there? Like, is the child not concerned about where the child is sitting and child is starting to masturbate? In Not in secrecy, inappropriateness, is that there?
No, no, no. Only when there is a lot of privacy or parents are not at home, when he really finds a time, that boy is engaging.
Even by restricting pornographic material, the child may continue engaging in doing that. There is no doubt.
Yeah.
Even if so, pornographic material is the problem in that case, isn't it?
Okay.
That can be dealt with rather than discouraging or shaming the child, or prohibiting the child from having fantasies, which is not at all advisable actually. You know,
Okay.
they should feel normal. They should have the right information about sex, right? They should have uh, lesser frustrations and more appropriate ways of dealing with it.
Okay. With that, you told he has to be spoken about it with the same sex, like if a son is doing it with the father. But if he is not having a good relation or comfort with him, how do he be spoken about it? Because you told
So
him mother cannot speak about it. He has to be taken to a therapist or
I said
father.
ideally with the same sex parent. Usually opposite sex parents, the discomfort levels may be a little high. Therapist also can help. Definitely, a professional therapist can also help. Um, Sometimes it is also important to look at it from a whole new angle. Now that you said that, may not be having a good relationship with the father, you should also consider how much child may be using masturbation as a way of coping. You know, there is a lot of possibility that when children feel excluded, children feel lack of happiness, childhood depression cases, sometimes engage in excessive masturbation. They try it as their only time of pleasure. They may start getting quite, preoccupied with it. So, if such situations are contributing according to your clinical judgment, then I would say that okay, build a relationship with the father if possible. If that is also not possible, then a therapist or so even mother or a sibling, if same sex sibling is there, they can help.
Okay. Okay.
So
Thank you.
stakeholders play a role.
Yeah.
So
I have one question.
yeah. Okay, so what might you suggest as a way to handle it if a male has an orgasmia? So there is erection, but there is no orgasm.
That is probably delayed ejaculation, isn't it? Or delayed ejaculation, or the long term of sex, but there is no climaxing, isn't that right? So,
Yeah.
sensate focus therapy can usually help in that also. Sensate focus therapy is usually indicated for that. Uh, it can happen because your arousal level does not take you beyond the point of plateau. Mhm. So, sensate focus therapy is targeting arousal. You start paying more attention to sensation and increasing your arousal. So, even sensate focus therapy should be enough to take care of, uh, uh, you know, um, uh, delayed ejaculation, or lack of orgasm, anorgasmia. That is possible even with sensate focus therapy. Sensate focus actually takes care of a lot of issues because sex is all about sensations and touch at the end of the day, rather than erection and penetration and ejaculation, right? So usually sensate focus is widely applicable in a lot of problems. Actually, we can also encourage masturbatory practices, fantasizing. These can be encouraged in the individual. Self-stimulating activities with fantasies, not using porn. Okay, I guess we are 20 minutes overshooting. So if you have any further question, I think it would be better if you could probably send it across through the coordinator. If you can compile the questions and send it, I'll answer it also. You can send it to the mail ID that is on the screen. You can also follow me in LinkedIn if you have any further conversations privately. If you have anything, you can contact me in LinkedIn. Thank you.
Thank you, Mr. Krishnan. Yes, ma'am. Ma'am, would you like to say something?
No. I wanted to got the opinion.
Okay. Thank you, Mr. Krishnan. It indeed was a wonderful session. But before we move on to a formal vote, I have a request for the participants. And the request has got to do with turning on your videos, but not yet. Okay, I will give a few instructions, and that is what I want you to do. After I count down from 3, 2, 1, it goes this way, that when I ask you to turn on the videos at the count of 1, kindly turn on the video. So as I give you the instructions, kindly tidy up yourselves, your surroundings if you need to, okay? And turn on the video for about 10 seconds, because I personally feel for this extremely enlightening session, Mr. Krishnan deserves a visual silent applause. All right, so shall we do it? This is a visual or a silent applause. So at the count of 3, 2, 1, kindly turn on your videos and we give a visual, a silent applause. Come on, guys, come on, you're young. Yes, that's good. Thank you. And this applause is for everybody who turned on the videos.
Thanks.
Thank you very much. And on behalf of the PT Counseling Department of School of Social Work, Roshni Nalaya, I would like to thank you, Mr. Krishnan, for the insightful knowledge parted by you on the sensitive topic, especially in our Indian society. this session was indeed beyond expectation, and I'm positive that it will be of extreme helpful or use to us in future for our counseling, the future in counseling, or there are also other participants who are also counselors and who know quite a few and a lot of things about this. Okay, I take this opportunity also to thank all the participants, especially the active participant, without whom the webinar would not have been a success. So thank you all once again, and let us all applaud for ourselves. Anybody with the videos on? Thank you.
Thank you. Thank you, guys. Thanks a lot, ma'am. Thank you for this opportunity. Looking forward to collaborate with you guys on many other topics also in future.
Thank you very much, sir.